Welcome back to another day. We have a really exciting morning this morning. Dr. Leah Carlson and Dr. Nikki Zarling are going to lead us through a women's health themed morning. So without further ado, I'm going to turn it over to Nikki.
Hi, everyone. I'm back for a little bit more women's health. And I really appreciate Leah letting me be a part of this. She's put a lot of work into a fantastic session about preconception counseling and contraception for rheumatologic disease. And I'm just going to be starting us off with a short session to just review those contraceptive facts and knowledge that will help us get started for her session. I also want to say that I'm going to be talking a lot about like the nuts and bolts of contraception, but less about strategies to actually do contraceptive counseling in your patient visits, which is also a very important topic. Effective patient-centered contraceptive counseling is really important, and Leah is going to touch on that briefly in her talk. So without further ado, I'll get started. To start out, we can talk about our learning objectives. What we're going to be doing today in this first session is organizing our contraceptive options by effectiveness, ease, hormone content, and systemic absorption. We're going to review common contraindications and risks to estrogen-containing contraceptives and the data supporting these conclusions. We're going to differentiate between different progestins and their side effects by generation. And we're going to also talk a little bit more about emergency contraceptive options. So our first part is just going to be reviewing our options. And I'm hopeful for a little bit of chat participation during parts of this as well. So this graphic is from a fantastic website called bedsider.org. If you're not familiar with it, I really encourage you to check it out and provide it to any patients of childbearing age to talk about their contraceptive options. But first, I just want to talk about our contraceptives by effectiveness. So this probably brings you back to med school or even early intern year. But the first group is those really effective contraceptives, less than 1 in 100 chance of pregnancy at a year, which is the implant, the IUDs, and sterilization. The next group is the contraceptives that work pretty well. 6 to 9 women or patients get pregnant kind of with usual use in a year, and that's the pill, the patch, the ring, and then the Depo-Provera shot. And then the last category is the methods that are a little bit less effective, kind of 12 to 24 in 100 patients getting pregnant. Those are things like pulling out, fertility awareness, and condoms. What about ease, though? What do you guys think are the easiest ones to use? And I would love if you put in the chat which one and why. I agree, Ruth. When I first was thinking about this question, I agree with you guys. Those set it and forget it methods are really easy, but you're totally right, Becca. Getting a procedure is super hard. And I was thinking more about like, what does ease mean? And so for many patients, easy is that like set it and forget it method. So either something that's implanted or a procedure, or something that you just don't have to remember to do every day or every week, things like the NuvaRing or the Depo-Provera shot. But ease is a really personal conversation. And for many people, ease is actually this group that's more client controlled and read, things that you can do without a doctor's visit or prescription. And maybe there's less effectiveness, but there's also a lower barrier. And so sometimes I find myself saying words like, oh, this one's really easy because all you have to do is get an IUD placed. But for many people, a procedure of getting an IUD placed is a huge barrier. Okay, talked about ease, getting a little more tricky now. Which of these methods contain estrogen? Pill and patch, agree. Oh, Sarah, you're an expert, new women's health faculty right there. There's 3 in this group. So the pill, especially the combined oral contraceptives. You also have progestin-only pills or POPs. The patch contains estrogen. And then there is also, it's a good reminder that the ring, the NuvaRing, also contains estrogen. And so what about those patients that don't want any hormones at all? Which of these options are not hormonal? Truly non-hormonal. Copper IUD, totally right, Priyanka. In the bottom row, and sterilization, Monica. I didn't even have a sterilization. I was running through this with Luke last night and he was like, sterilization. I was like, good point. That is non-hormonal. So those are 2 really long acting options that are non-hormonal. And then Priyanka, you're totally right. That bottom row also doesn't have any hormones, which is really a priority for many patients. I also wanted to take a little bit of time for partially my own learning to talk about, in the hormonal options, what is the systemic absorption look like? How much hormone is commonly absorbed? Because at least in my counseling for IUDs, I often tell people, oh, there is no or minimal systemic absorption of these progestin compounds. But looking at the data, there actually is a little bit of systemic absorption. You can see in the top part of this table that there is some systemic absorption of both the Mirena and Skyla IUDs. As a reminder, the Mirena is that highest dose levonorgestrel IUD. And Skyla is the lowest dose or smallest progestin IUD. However, both of those options are quite a bit less systemic absorption than other options, including Nexplanon, the mini pill, the shot, the NuvaRing, and the patch. The highest for both estrogen and progestin levels of these contraceptive options is combined oral contraceptives or the pill. But you can see here, comparing it to a natural cycle, and your peaks of progestin and estrogen during a natural cycle are far higher than any amount of hormone that you're getting through any of these contraceptive methods. For me personally, I generally counsel patients right along this line of systemic absorption, saying, oh, you know, Mirena and the other IUDs are minimally systemically absorbed. But after looking at this data, I think even I'm going to be doing my counseling a little bit differently, because a Mirena IUD, especially early on after placement, hormone release is at its highest, and it's probably comparable to a Nexplanon. But obviously there's huge patient factors. The other thing to acknowledge is that the IUDs their hormone release does not necessarily inhibit ovulation. It more acts through other methods. I also want to share a little bit about a new non-hormonal option for contraceptive that was recently approved, and it's called Phexxi. You can see it here. It's a vaginal gel inserted with this applicator just prior to intercourse, and it changes vaginal pH, impairing sperm motility. You might think of it as kind of a spermicide, but it works really through a different mechanism of action, where spermicide obviously kills sperm, and this just renders them immobile. It's pretty effective, 93% with perfect use, and importantly, it does not contain hormones. And right now, I feel like we kind of have minimal options for patients who do not want any hormones or have a contraindication to hormones. However, it is pretty expensive. Good question, Becca. Becca Stevens asks, does this increase BV infections? She's probably using some good physiology here and thinking about how BV, we think, is related to changes in the vaginal pH. And there is an association with increased rates of BV, yeast infections, UTI, and vaginal irritation. Ruth, I don't know about imperfect use, but often kind of that 80 to 90% is something that I think about. And then spermicide with the diaphragm, Priyanka, it can be used alone, but you can also use it with a condom is what I remember. But if Roxanne or Sarah or Leah have other thoughts about that, I welcome their knowledge. The big thing that you can't use this with is the vaginal ring, like a NuvaRing. In the spirit of full disclosure, every time someone from Women's has tried to prescribe this, it's been prohibitively expensive, but I hope that it becomes more accessible to patients in the months and years to come.
I've prescribed it once, and I think you get 12 for a month, and it's like 200 or $300 if I recall. She wanted to pay though, so.
So for some people, this is a really, compelling option. But yeah, $300 is a little bit steep. Okay, we've done a big run through all of these different contraceptive options and sorting them by different criteria. Any questions so far about contraception? Totally fine. We're going to move on to part 2. Oh, yeah, Ruth. Comparing your Phexxi to a copay for an IUD, and many insurance companies, like Good Commercial Insurance, does not have a copay for an IUD through the Affordable Care Act. Okay, next we're going to talk a little bit about estrogen. Lauren, sorry, I'm going to quick talk about some bleeding profile for the hormonal methods. Let's see if I can go back. So we can kind of look at this table in terms of different methods, and I can kind of run through it quickly. I think it really depends on what risks your patient is willing to tolerate. So in most hormonal methods, your period should become lighter over time and a shorter duration. However, all of these methods have a pretty significant side effect of irregular bleeding, which can be really frustrating for a lot of patients. Especially things like the progestin-only pill, Depo-Provera, and the IUDs. Patients can be really understandably bothered by irregular spotting and irregular cycles, versus things like oral contraceptives. If you have a withdrawal bleed every month, usually people have fewer side effects, although there does take some kind of titration of your estrogen and progestin doses for that. One negative of the longer acting methods like the IUDs and the Nexplanon is that obviously then you have to undergo another procedure if the bleeding risks are not tolerated. And so things like Nexplanon, actually up to 1 in 6 women or patients get it removed due to intolerable bleeding side effects just due to irregular spotting, which is always surprising to me. Okay, I'm going to talk a little bit about estrogen now, and this is kind of relevant for later in our talk. I just want to take a step back and say, how do we even know which patients are eligible for these different types of contraception? And we're lucky that the World Health Organization and the CDC have created some resources that help us determine eligibility by medical condition. This table might seem familiar from your OB-GYN rotation in medical school, but they're a little bit hard to interpret. Essentially, it's based on each medical condition listed on the left side of the table. What is the relative contraindication to different types of contraceptive options? Again, I find these tables a little bit hard to interpret. So the World Health Organization has some resources that I find a little bit more user-friendly. Again, MEC is medical, oh gosh, I have managed to forget what it even means. But there's an online website that I have here called the MEC Wheel, where the medical eligibility criteria, there you go, Priyanka. So on the outside of this wheel, you see different medical conditions. And if you press these arrows, you're going to move back and forth between medical conditions, and it's going to say via these numbers what the relative contraindication to different contraceptive options is. So you can see here a history of venous thromboembolism. A copper IUD has no contraindications, while a combined oral contraceptive is a strong contraindication or a level 4. There's also an app that shares the same information that's pretty helpful. It's called Contraception. If you search WHO contraception, you should be able to find it, and you can select one or multiple medical conditions and then also select different patient factors like long-acting or non-hormonal, and it will help sort different contraceptive options. Overall, though, the most common contraindication is to estrogen. And so we're going to review some of those common contraindications and risks of estrogen, including migraines, thromboembolism, and breast cancer. First, I want to talk about migraines and estrogen. As many of you probably know, estrogen-containing contraceptive options are contraindicated in patients with migraine due to the increased risk of ischemic stroke. And what we know is that migraine with aura independently increases stroke risk, and combined oral contraceptives also relatively increase ischemic stroke risk. But to remember too that the absolute risk for both of these is actually quite low, and we're going to kind of get into some numbers. And especially in this section, I think my take home is to say, really think about your particular patient and their individual risk when prescribing these medications. And there's kind of this new growing movement saying, are we being too strict with patients with migraine with aura in banning them from getting combined oral contraceptives? One factor is that new OCPs have much lower doses of estrogen compared to the studies in the 70s that originally informed risk. So those prior studies, every patient who had a stroke on a OCP was taking at least 50 micrograms of estrogen a day and is up to 150, while new oral contraceptives are generally less than 30, and we have options that are as low as 10 or 20. We also know that individual stroke risk depends on some patient factors, like someone with infrequent migraines with aura is at lower risk because the stroke risk is correlated to migraine frequency. The other reminder I want to share is that stroke risk also increases in pregnancy. So a woman not on a pill without a migraine has a baseline risk of 2.5 per 100,000. Migraine with aura is 5.9 per 100,000, and pregnancy is actually double that. 13.4 per 100,000, and migraine in pregnancy further increases risk. And so I share this mainly to say that even though these governing bodies say that this is contraindicated, there are situations where this might be appropriate. Especially, I always go back and say stroke risk is higher in pregnancy. If a patient only wants an estrogen-containing contraceptive, and the trade-off is an unintended pregnancy or a stroke during pregnancy, I think that's a risk-benefit conversation that's reasonable to have with your patient and document well. So my own practice pattern is if someone has infrequent migraines or an infrequent aura and is interested in estrogen-containing contraceptives after comprehensive counseling, and I've had a high-quality risk-benefit conversation, then I'll prescribe. And on the left side of this slide, you can see some of those very low estrogen options. So low estrogen is the lowest amount of estrogen. NuvaRing is fairly low as well. And then one of our bread and butter oral contraceptives is low estrogen. I bet many of you have prescribed that, and that's just 20 micrograms. Okay, next I'd like to talk a little bit more about thromboembolism and estrogen. So how does estrogen increase thrombosis? And it's through a lot of different factors. It increases von Willebrand levels, it increases plasma levels of different clotting factors, and increases protein C and decreases antithrombin. And all of this tips the scale towards a prothrombotic state, both venous and arterial. Again, we should consider kind of the individual risk factors for our patients. It seems that risk for clot is greatest in the first 6 months and returns to baseline within 3 months of discontinuation. And oral administration seems to be higher risk than transdermal. There's also a role of progesterone here, actually. And the risk is higher with higher generation progestins, which I'll get into in a little bit. And again, we need to remember that pregnancy is also a high estrogen state. So we're always weighing those risks and benefits with a kind of a meaningful conversation with our patients. I learned that pregnancy is such a high estrogen state that if someone has had a blood clot on an OCP, then ASH, or the American Society of Hematology, does recommend antepartum and postpartum thromboprophylaxis. The last major risk factor that I want to discuss is estrogen and breast cancer risk, which some of your patients may be concerned about. The big question is, does estrogen-containing birth control increase our risk of breast cancer? And there's lots and lots of big studies looking at this right now. The one that I want to highlight is a study published in New England Journal of Medicine in 2017. That was a nationwide prospective study from Denmark, studying 1.8 million women for more than 10 years. And their conclusion was that the risk of breast cancer increases slightly in hormonal contraceptive users versus non-users. And this is all comers, not just the pill, and that the relative risk decreases after discontinuation. So you can see here on the left-hand side of this table that risk increases with duration of use and then decreases after discontinuation. Their conclusion was that the risk of breast cancer is higher among women who are currently or recently used hormonal contraceptives compared to never users, but the absolute risk was low, about a 20% relative risk. And that other studies have shown that the increased relative risk is minimal or nothing after 10 years of discontinuation. Again, this, for some people, you might say, oh, wow, this is kind of an unacceptable risk, but I want to encourage us to think about some other factors, like that overall risk is low. So in all comers, the increased risk correlates to about 1 case per 7,700 women. And in patients under 35, the risk is even lower, just 1 additional invasive breast cancer per 50,000 women. I also think it's an opportunity to think about the other benefits of hormonal contraceptives, specifically with respect to cancer. Hormonal contraception is associated with a decreased risk of ovarian, endometrial, and colon cancer. And some studies suggest that overall cancer risk may be slightly lower despite the small increase in breast cancer risk. You can also think about ways to harm reduce or decrease risk of breast cancer in other ways. Risk was reduced based on estrogen dose and duration, so a lower dose of estrogen for less time. And we always have the opportunity to address other risk factors for breast cancer, like smoking, alcohol use, and inactivity. So my take home from this data is to think about counseling differently in someone who perhaps has a higher baseline risk of breast cancer, like a strong family history, but in a kind of the average patient, the breast cancer risk is not significantly increased over time. Next, I'd like to briefly review progestins, but before I do that, does anyone have any questions about estrogen and estrogen contraindications? Okay. Part 3, a brief review of progestins. I feel like we don't get a ton of teaching on this, so I just wanted to kind of briefly run through things that I've learned in the last 3 years. And as a reminder, progestins in contraceptives support the endometrium, thicken cervical mucus, and make the endometrium unfavorable for implantation as their mechanism of action. There's actually 4 major generations of progestins that we use, and there are oral contraceptives that use them all. The first generation progestin is norethindrone, which is the lowest clot risk. As we previously discussed, these more advanced generations have slightly increased clot risk, but it's the shortest half-life, which for many patients, going back to Lauren's question, they do notice spotting with this medication because it barely lasts 24 hours. So if they're a little bit late, they may have some spotting. As we move up the generations, their half-lives generally increase. And then as we get to the 4th generation, we have some additional benefits, including an anti-androgen side effect. So drospirenone is the progestin seen in Yaz or Yasmin. And so as you can see in this table, there's some advantages and disadvantages to each option. The earlier generations of progestins also have a risk of slightly higher androgenic effects. So in some people, this is kind of the theory why some people get an IUD and they feel like their acne gets worse. A hormonal IUD is levonorgestrel. And if there is some systemic absorption, theoretically, it could slightly worsen acne. There's also a new generation of progestin-only pills. So all of those progestins can be prescribed in combination with a ethinyl estradiol and a combined oral contraceptive. But the 1st generation and now the 4th generation can also be prescribed as progestin-only pills. So previously, progestin-only pills were challenges of use were that you had to take it very consistently at the same time every day for maximum efficacy. But recently, a new progestin-only pill called Slind, I don't know how they come up with these names, was approved. And this is the progestin found in Yaz or Yasmin. It is a progestin-only pill, and it has a longer duration of action, up to 24 hours. So you don't have to be as strict to take it at the exact same time. It's 96% effective. It's also dosed 24 plus 4, so 24 active pills and then 4 placebo pills, which is comparable to kind of a traditional oral contraceptive. And that's compared to just a continuous 28-day dose with norethindrone or a traditional progestin-only pill. It's also okay to use this when breastfeeding, just like other progestin-only pills. And there's a theoretical risk of hyperkalemia due to its anti-mineralic corticoid effects. Ruth, I don't know the actual physiology behind the placebo pills for this one. Okay. After our brief tour of progestins, I want to take a second to talk about some new information about emergency contraceptives. My final table stolen from bedsider.org is this great table about emergency contraception. And I do think this is decidedly within the primary care wheelhouse. The top row is the copper IUD. And interestingly, this is not FDA approved for emergency contraception, but we know it's highly, highly effective within 5 days. However, like we've talked about, there's some barriers. You have to get to the doctor to get an IUD placed within 5 days of unprotected sex. The bottom two are FDA approved, and that's Ella and Plan B, which I'll talk a little bit more about. Those are both hormonal pills that block ovulation to decrease the risk of an unintended pregnancy. There are no significant contraindications to Ella or Plan B, and maybe Leah will have other thoughts about this during her talk, compared to use of combined oral contraceptives or progestin-only pills, simply because the duration of hormone exposure is quite a bit lower. So if someone has a history of migraine with aura or other kind of estrogen contraindications, I would not use that as a reason to not prescribe these medications. So a little bit more about Ella versus Plan B. A lot of us are familiar with Plan B. It's available now over the counter, and it's a progestin, it's levonorgestrel that blocks the LH surge. It's most effective up to 3 days after unprotected sex, and sooner is always better. However, new data is coming out to suggest that in patients with a BMI over 25, it's really not very effective, which really limits its use in many of our patients. Ella, on the other hand, is more effective at kind of across the BMI range, but it's available as prescription only, which is definitely a barrier. It's an anti-progestin, which delays ovulation by up to 5 days, allowing sperm time to die, and inhibits both pre-ovulation and through the LH surge. You can, even though it's prescription only, patients can buy it online. There's websites called Nurx or Project Ruby that you can buy it for about $50. And the weight limit is a little bit less significant, but there is some data to suggest that over 195 pounds, it's less effective. And just a reminder that neither of these is 100% effective. So with Ella, it's about a 1 to 2% pregnancy rate, and Plan B, it's a 1 to 7% pregnancy rate. Generally, my practice is that I prescribe Ella to most patients not interested in pregnancy, but not routinely using a highly effective form of contraception. And the OB-GYNs are maybe even a little bit more aggressive than me. And once I was in an OB-GYN clinic and they were like, we just sent Ella to your pharmacy, just like if you need it. And I think it's just a good reminder to kind of have for patients to have in their back pocket if they do have unprotected sex, and to make it a little bit more kind of patient-centered to allow them the opportunity to use. Caitlin shares some valuable information. It's a good option for transmasculine patients to have birth control without estrogen and without a procedure. That is really always good to know. And Roxanne shares too, they always send Ella to the pharmacy. So this is a really good option, and I definitely think is within the primary care wheelhouse. I also want to share some new data about other options for emergency contraceptives, specifically levonorgestrel IUDs. It's a new study from New England Journal of Medicine in 2021 that randomized patients who were requesting emergency contraception after at least one episode of unprotected intercourse within the last 5 days, and they were randomly assigned to the levonorgestrel 52 milligrams, which is Mirena or Liletta, or a copper IUD, and it was a non-inferiority study. The results are here. There was ultimately one the outcome was a positive pregnancy test 1 month after placement, and there was one pregnancy in the levonorgestrel group and no pregnancies in the copper IUD group, with similar rates of adverse events. As you can see here, the confidence interval across all these different analyses crosses 0. And the conclusion was that the levonorgestrel IUD was non-inferior to the copper IUD. Another advantage of both of these options is that they can be used in patients of any weight. There are some kind of caveats to this study. It's only one study and it's a smaller patient population versus lots and lots of studies have showed the effectiveness of copper IUD. But the reason I think this could really change the game for a lot of patients is that many patients don't want the copper IUD due to intolerable bleeding side effects. So the copper IUD generally increases period volume and duration and can increase crampiness too. So in many people choosing an IUD, the opportunity to choose a hormonal IUD instead of a non-hormonal IUD is really beneficial. Oh, Caitlin's still talking about Slind. Sorry, Caitlin. Jocelyn, does anyone off-label give more pills for higher BMI the way we do for other weight-based dosing? So this is back talking about emergency contraception. And I was reading about this, Jocelyn. It looks like when you give like twice the dose of Plan B, the blood levels of levonorgestrel are comparable to patients with a lower BMI, but we don't actually have data to say that that means it's more effective. There still seems to be issues with effectiveness, and that could potentially be due to metabolism or drug storage or things like that. Nick, why is the copper IUD not approved for not FDA approved? I don't know. I'm sorry. You should still be able to get it approved just for contraception for most patients. Realistically, Priyanka, where would you counsel patients to go to get emergency contraception IUD? They don't always have that kind of availability. That's really a fantastic point. So I think that this is actually one of the major barriers to IUD placement for emergency contraception. It's easy for me if a patient calls in or sends me a MyChart message to prescribe Ella, but an IUD is a lot harder. So part of there is some access at UW Gyne for placement. Often if you call saying it's for emergency contraception, they can try to squeeze patients in, but this is when resources like Planned Parenthood is really helpful for patients, but even Planned Parenthood can have long wait times. I think to counsel your patients to say this is for emergency contraception and help them kind of learn that language of medicine is really helpful. So we're wrapping up. I want to just review what we have learned, which is that we have lots of contraceptive options for patients, hormonal, non-hormonal, long-acting, prescription only, over-the-counter, and more. Estrogen is contraindicated in many medical conditions, but there's limited data using our current estrogen and progestin doses. As a reminder, higher generation progestins increase our clot risk, but are also less androgenic, which is a potential benefit. And I really, if there's one thing I want you guys to take home is that internists can and should prescribe oral emergency contraceptives to their patients, even though IUDs are likely the most effective form of emergency contraception. Okay, that was a whirlwind tour of contraception. And let me stop sharing my screen. And I think we have a little bit of time to answer some questions if anyone has any.
Great presentation, Nikki. Random question. Do you know which birth control option would be best for like a patient with endometriosis, or do you normally refer out to Gyne for that?
That's a really good question. So most of the time with endometriosis, we like things that suppress ovulation. So IUDs are not as good of options, just given the lack of ovulation suppression. So things like combined oral contraceptives or progestin-only pills generally inhibit ovulation. I just was on Instagram and an OB-GYN said that Micronor, which is norethindrone, has some anti-inflammatory effects, which could be beneficial for endometriosis, but this was like literally me on Instagram this morning. So that is not evidence-based. Generally too, more about endometriosis is that almost some patients with endometriosis are really reluctant to have a hormonal option but the OB-GYNs generally will not do surgery or other interventions without a trial of hormonal options as long as they don't have an obvious contraindication to hormones. So sometimes I have the advantage that like I am a women's health provider, but I have lots of patients that have had not as good experiences at OB-GYN, just feeling kind of dismissed in their symptoms and their experiences. There's also, as a reminder, there's no obvious reason why people can't have an IUD for super effective contraception and then take a mini pill or a oral contraceptive on top of it. It does increase your hormone exposure slightly, but like dermatology sometimes does that in people with acne. So potentially the combination of the two, if people are concerned about conception, is an opportunity too. There's some conversation about Ella at the VA. I'm sorry that I don't know more about that. Overall, that's all I have for you guys. Leah has some great content coming up about how to apply this to patients in the rheumatology setting, but I think Sarah said we can take a break first.
Yeah, thanks, Nikki. That was awesome. Why don't we take we'll do a 10-minute break, kind of our standard. Let's come back at 9:49.